announcements. And then we'll wrap up. So let's start out with quick intros. If you don't mind, Christina, taking down the slides. If anybody is attending this meeting for the first time today, we'd love to hear from you. So your name, your organization, and your GLOW, which is 5 words or fewer describing something you're passionate about. And if you're a regular member of COVID, if you don't mind, please put your name and organization in the chat. So I will open the floor to see if there's anybody new that wants to introduce themselves. Okay. I'm trying to be comfortable with a long, awkward pause, but it looks like there's nobody new so far. Okay, so I'd like to welcome Jancita Warrington today to the Kansas COVID Equity Task Force. She's going to be with us from now on. She's the Executive Director of the Native American Affairs Commission, and I'd like to pass the floor to her right now to share a little bit about herself and her plans for the commission. Jancita, the floor is yours.
Hi, everybody. I would like to introduce myself. My name is Jancita Warrington. I am Menominee, Potawatomi, and Ho-Chunk. I was born and raised in the Great Lakes area on my dad's reservation at the Menominee Indian Tribe of Wisconsin. The Potawatomi and Ho-Chunk people also come from the Great Lakes area. And so I am happy to be in this position here serving the governor and have a lot of great colleagues that I've met so far. Some things that I'm passionate about is cultural preservation management and education advocacy. I have degrees in tribal law and policy and cultural preservation management, and I have an undergrad in American Indian Studies and education. I plan to make the position of the Kansas Native American Affairs Office a little more visible and interactive. I really plan to do a lot of advocacy and education in my position, both in the governor's office and with the legislature as the opportunities allow. I am happy to be a part of some of the education task force already to help to propel some of the much needed cultural relevancy in education and be able to create standards and curriculum here that doesn't exist in the state of Kansas, as well as work on some legislation for tribal consultation and also just tribal advocacy at the executive level. So I'm happy to be part of the COVID task force. Bettering our communities and the health of our communities is also something that I take very seriously, and I'm excited to do what I can and work with this committee to help to make better relationships and new engagements with tribal communities and organizations that serve our communities. So if anybody has any questions or anything that I can do to help, you can reach me at jancita.warrington@ks.gov, or if you look on the state of Kansas's website and look for Kansas Native American Affairs Office, they have their own website as well, and my information is listed there as well. So thank you.
Thank you, Jancita, so much. Thanks for being here and thanks for your work. I'm so glad that you're here. Okay, so we're going to shift gears now and take a look at the data for COVID vaccine in Kansas. So grateful to have Jamie Gable here with us today to walk us through the data. Jamie is a senior epidemiologist at KDHE. Jamie, you have the floor.
Thanks, Dr. Garcia. Do you have my slides up, or do I need to pull them up?
Yeah, we have them.
Okay, if you could just go to that first slide, thank you so much. We're just going to go through, and most of the data is going to look familiar to you and going to look similar to what you've seen in the past, and it will definitely look like what you saw last month when we presented. So what we're seeing here is we've added tender age vaccine to our first dose. Next month, you'll also see tender age added to the completed full series. Right now, it only has the first dose, and we only have about 2% of Kansans in the tender age category that have received their first dose, which As of the update that this was on the 13th of July, that was about 4,200 kiddos in that age group. And that is updated on our dashboard, and we'll have a more recent number from yesterday if you look on our dashboard. And so we see that that uptake is going very slowly, but our total population and elderly population uptake is quite high, and adult population is also quite high. And we also see that we have our completed series and eligible that have received an additional dose or a booster. And as a reminder, when we say additional dose or booster, this does not equate to people who are up to date with vaccine. The reason why we do not equate it to up to date vaccine is because the up to date definition is highly, highly dependent on people's medical conditions and different health factors. And we do not have that information in WebIZ. WebIZ is an immunization registry, so it is not capable of telling you if somebody is actually up to date or not. So we can only tell you who has received a booster out of who is eligible to receive a booster. If you could please go to the next slide. So to explain that calculation for the booster, we are looking at the age 65 plus as an example. So we're just looking at who's received a booster or an additional dose out of who is eligible. So it's looking at who's eligible rather than out of the entire population. So because of that, this is sort of an evolving number. It will go both up and down instead of continually going up. So when there's more people eligible, but some of them haven't received boosters, the percent that have received a booster out of those that are eligible may actually decrease from time to time. So we have 662 people in the age group that received their primary series and they're eligible for a booster. Out of that, 305,243 received something beyond a primary series. So that means 72% out of those who are eligible have received a booster or an additional dose. If you could please go to the next slide. Thank you. This looks at our under age 18 vaccination by different racial groups and by ethnicity groups. As you can see, even with the addition of the tender age, which is just going to be represented in the increase from the June to July mark, it really still has largely stagnated, and most of the groups have not gone up that much, even with the addition of an extra age group. If you could go to the next slide, please. So we have an additional slide on the American Indian Alaska Native vaccination. And the reason why we do this, and theirs doesn't look like the others, because we haven't determined what we consider to be an accurate way to capture this information yet. In Kansas WebIZ, we know that our numbers for the American Indian population are quite low. And we know that if we just look at IHS numbers, those are not necessarily accurate either, because they look at anyone who was vaccinated through IHS, which that person may or may not be Native, and that may or may not be already counted in Kansas WebIZ. So we can't add them together, and we can't necessarily consider them completely accurate separately. And we know that in Kansas WebIZ, we do have what might be considered an overcount of people who are multiracial, while also undercounting American Indian and Native Hawaiian numbers. It is our belief that people who identify in these areas would also identify as other races and are counting as multiracial. And because it's self-identifying, we don't want to change how they identify themselves, but we also know that it may be a little bit of a disconnect based on what our census numbers are for some of these population groups. So because of that, it is making our percentages look much lower. And this may be a discussion that Dr. Garcia has with a smaller group who is specifically interested at a later date. So we can discuss what our numbers for Kansas WebIZ look like that have Native American mark that are also multiracial, to see what that percentage might look like and if we think that might be a more accurate count. If you could go to the next slide, please. So adult vaccinations are even more stagnant than under 18 vaccinations. And I mean, they really have not increased very much over time. We do see a little bit of an increase in the Hispanic Latino compared to other. And part of the reason for that is because the way the data from the back end of WebIZ was being pulled, it was actually, there are some very specific racial groups that can be marked like Cuban or Panamanian, and those were not necessarily in the coding on the back end being considered Hispanic or Latino when they should be. So that was fixed recently so that all of those are being correctly categorized. If you could move to the next slide, please. So the same issues that exist for the under 18 for American Indian Alaska Native also exist for the over 18 adults. So we know that this number of 24% from Kansas WebIZ is definitely an underestimation of coverage. CDC for the entire country, it estimates at 73%. We would assume that ours wouldn't be significantly different than that. So we are looking to find a way to more accurately capture this while still holding on to correct methodology and integrity of the data. I think that is our last slide.
Thank you. Thank you, Jamie, for providing the data and also walking us through it. I really appreciate your offer to think through the data that we look at, specifically around Native American vaccine. And I would really love to have a meeting with a smaller group who might want to talk about this with us. So if you are interested in doing that, do you mind just sending a message on the chat, and then I can coordinate and we can set up a meeting. Does anybody have any questions to ask Jamie about today's data? Okay, all right, thank you. Well, we'll move on. So next up, we're going to hear from Rosalind Brown, who's going to share how she's using her PAVE grant dollars to do COVID vaccine work. And I'm going to pass the floor to Courtney to introduce Rosalind to the group.
Thanks, Dr. Jimena. So I just want to give my appreciation to Miss Rosalind really quickly. She and Virgil were among the first partners that I connected with when I came on, and Rosalind was always gracious, and she's also one of the first partners that walked through the PAVE process with Dr. Jimena and I, sort of in our unique process to try to make it easier to acquire the funding. So Rosalind, in addition to all of the other work that she does, is a really strong leader in the faith-based community across Kansas. And I'm excited to see how she's gonna give her spotlight today. So she's doing it a little bit differently than anyone else has done, and is gonna give you a little visual of her work. And with that, Miss Rosalind, I'm happy to have you start your presentation.
Well, thank you so much. I'm not a talker, so you won't have to worry about me going over my time. But I do want to say good afternoon to everyone on the line. And I wanted to thank Dr. Garcia and Courtney for their support and this opportunity to make a difference here in Wyandotte County for the state of Kansas. We are located at 2106 Quindaro Boulevard in the heart of the urban core of Kansas City, Kansas. Wyandotte County was identified early in the pandemic as a county in the state where minorities were largely unvaccinated. Our church organization was also identified as a hotspot initially. We had a conference and there were a number of people who were infected during that conference. And so some of our congregation lost their lives and others were affected for long periods of time. But it was the desire of our leader, Bishop Thurston, to do everything possible to make sure that we could help the people that were attending our church, but not only our congregations, but the community. So that's why we were excited about having the opportunity to get involved and be a part of what's going on here in Wyandotte County. We have been working with partners like the Unified Government of Wyandotte County, Health Department, Vibrant Health, and the medicine shop that administers some of our vaccinations, healthcare workers of Wyandotte County that canvass the neighborhoods to make sure that our flyers and information is put on the doorknobs of the houses in the area. We work with the healthcare workers of Wyandotte County. And we also have had during our time, Harvesters has come out to encourage people to come and be a part of the testing and vaccinations. We are also a member of one of the Wyandotte County Health Equity Committee that also is working in Wyandotte County. We have churches not only here in Wyandotte County, but throughout the state of Kansas. So it's our desire to make a difference in more than just Wyandotte County. But making sure that those in Kansas, in the state of Kansas, are vaccinated when necessary. We're working with a consultant now to see what ways we can come together to do a better job at getting our information out to the community. And we're working hard to make sure that we hear what they're saying that their needs are. I think some of the times we don't hear from the people. We decide that this is what they need and then we're going to do it for them. But we need to hear from them what it is that they're needing in our community, because we do know there is a disparity and we want to get rid of that.
Yeah.
I was on a webinar yesterday with the Conference of National Black Churches, and we were challenged to do our part in making a difference. And one of the things that was said, that God loves us all. So there's no reason that we can't make a difference in making sure that everybody gets covered in all of their opportunity, all the things that we have available to them. One of the things I've also found in working with the community, sometimes people right in our own backyard do not know what's available to them. And that's why we want to get out and about and make sure. And sometimes because we are in areas that are smaller in the state of Kansas, we want to make sure that those people are not overlooked and just not aware of what is going on in their own community. So Kansas East is really going hard at it, and we want to make a difference. And we want to make sure that we're doing everything we possibly can to make sure everybody has the opportunity to be vaccinated and tested when possible. And basically, if you have any questions, I'd be happy to answer.
Thank you so much, Rosalind, for sharing with us. Oh my gosh, and your work. It's very impressive, and you've been such a great partner to the state and your community, of course. Does anybody have any questions? Okay, well, thank you again, Rosalind.
You're welcome.
So we're now going to hear from our featured speaker, Dr. Jason Glenn. Dr. Glenn is an associate professor at the Department of History and Philosophy of Medicine and director of the Repair Project at the University of Kansas Medical Center. His areas of research specialty include health inequities, mass incarceration, the history of drug policy in the US, and the ethics and history of human subject research. He spent 12 years at the University of Texas Medical Branch at Galveston as the James Wade Rockwell Distinguished Professor in Medical History within the Institute for Medical Humanities before relocating to KUMC. Dr. Glenn is also a founder and past director of Sobriety High, Inc., a nonprofit organization providing community re-entry services for persons with a history of substance abuse who are returning to Galveston from prison. Dr. Glenn was also a co-founder of the Galveston County Restorative Justice Community Partnership and the Galveston County Hope Drug Court. His current research investigates abusive policing practices as a structural determinant of ill health in so affected communities and improving the delivery of healthcare for persons who are incarcerated. Thank you so much for being here, Dr. Glenn. We'll now pass the floor to you.
Thank you so much for that introduction. It always feels a little embarrassing for me to hear my bio read out loud. I am delighted to be here with you all and try to give you what is really a quick and dirty sort of overview on the history of systemic racism in medicine, particularly in the United States, as a way of sort of understanding and trying to wrap our minds around the legacy of distrust and mistrust that we have inherited because of this history of systemic racism. So, like I said, what I'm going to try to cover in this half hour is really brief. Try to give you some examples in different realms of systemic racism and how it works in medicine. And get out of there. Okay. I want to start us off on some shared definitions. Race is a way of seeing and being in the world. And it is a relatively recent human invention that first emerged in the 16th century as a European religious, come natural philosophical system of classification, demarcating so-called civilized Christians from barbarous pagans. And as such a system, it has provided the moral justification in European eyes for the globalized system of colonial exploitation and enslavement that has created our modern world. Continuing with how it has manifested itself over these past 500 years, European and American intellectuals gave race a veneer of biology in the 19th century. And it's that definition of race that we inherit. It transformed it into the assumption that a few specific phenotypic or outer features, right, are perfect proxies for innate morphological and or genetic differences between groups of people so defined as races. And that's the idea of race that we have inherited and continue to pass on, this idea that we are distinct genetic groups of people based on, and being able to discern that based on our outer physiognomic appearances. Finally, the racialization of medical thinking is the process that has translated, right, this medical racial folklore circulating in the larger society into a medical doctrine of perceived, right, and usually imaginary racial differences. So there are a number of domains of systemic racism in medicine that I would try to cover with a few examples today. One is sort of cultivating and propagating and upholding the idea of race as an indicator of biogenetic difference. And this, as I said, emerged in 18th through 19th century efforts to place the religious and natural philosophical theories of race into a discourse of biology. Also, the racialization of standard allopathic medicine, including the sort of generation of racialized medical knowledge that we teach to students, so-called race corrections and clinical algorithmic decision-making, which I'll cover some of later, bias in the clinical encounter. And the third domain would be exploitation and abuse of racialized others in the production of biomedical knowledge. And so I'll talk some about the history of systemic exploitation and abuse of people of color in the history of human subject research. That includes experimentation on slaves, on prisoners in the US who have been majority people of color, and on poor people of color as well, and then as well on poor people from other countries. And then finally, the fourth domain, we'll talk about the mechanisms by which structural racism can impact health. It begins in the earliest part of our history in plantation medicine, which saw a lot of efforts at proving social hierarchies as biologically ordained. The interaction of the medical profession with the institution of slavery was, it was elaborate and it was profound. And it started with a soundness practice, right? Where doctors were hired to basically evaluate Black persons for sale to certify for their owners how good of a slave and how productive and long living of a slave that they could be. This is an excerpt from a novel called Brazil by Earl Lincoln Uis that talks about this process whereby doctors evaluated the soundness of Black bodies for sale. Plantation healthcare was delivered as a form of social control, first and foremost, simply in the acknowledgement of when a slave was legitimately ill. And this was a role that doctors happily played a role in and took money for. Owners delayed and denied their slaves access to medical care by routinely accusing them of malingering. And physicians who treated slaves were in this position of conflicted dual loyalty, torn between, right, the needs of their patients, right, and the demands of slave owners who were paying for their services. And they usually faltered on, or they usually went back to the demands of the slave owners over the demands of their patients. Their prognoses were a constant negotiation with slave owners to define what constituted a legitimate medical issue, and therefore a valid excuse from work assignments. And in this way, healthcare was administered not for the well-being of the slave, but rather for the maintenance of the slave's body to remain productive, and where the slave was the patient, but not the client to whom the physician had primary fiduciary responsibility. I talked about this term malingering. All slaves, and this is a practice that continues with prisoners today, were generally suspected of malingering when they made health complaints. And slaves were not believed to be ill unless indisputable outward signs and symptoms of disease were displayed. And owners relied upon the medical profession to diagnose malingering slaves. And doctors published articles on experimental methods to detect a malingering slave, which often featured all manners of abuse. One student at the Medical College of South Carolina actually devoted his thesis to the feigned illness of slaves. And this was back in a day when medical students had to actually write a thesis to complete their degree. And this included suggestions on best whipping techniques to discern a malingering slave. Other doctors suggested even more extreme methods, both physical and psychological, which included threats of physical harm, such as pouring boiling water on the slave's legs, but then using cold water instead, or setting fire to the suspected malingering slave's clothes or their bed to see how quickly they would get up and run, threats of castration, and in the most extreme, an insertion of a red hot ramrod into the rectum. There was an entire business of slave medical care, which included involuntary medical experimentation. That was a hallmark of enslavement. And furthermore, medical training, which then included mostly apprenticeships and through private practice, the few colleges that had sprouted up, the hospitals, the journals, and state medical societies, all were based in the traffic in and exploitation of Black bodies in various ways. These included trying out heroic purges and bleedings and cathartics that were often tried on slaves first to prove, if not their efficacy, to prove that they wouldn't kill white people when done on them. Slave medicine constituted the majority of business earnings for most Southern physicians during this period. And doctors routinely advertised in Southern newspapers that they would pay cash for Black people suffering from chronic disease in order to experiment upon them. And slaves who had become too old or too sick to work or breed were sold to doctors expressly for experimentation. The most famous of this is probably James Marion Sims, who was a pioneer of gynecological surgery. We have Sims to thank for the development of the speculum and of surgical forceps. But he became famous in repairing vesicovaginal fistulas, which were the ruptures that can occur between the vaginal walls and either the urethra or the rectum during childbirth. And it is a really debilitating process that can happen while giving birth, and without proper repair of those fistulas, it can lead to a debilitating life. In order to perfect his technique, Sims was granted control of at least 6 enslaved women as research subjects. And he subjected each of those women to as many as 30 vaginal surgeries, perfecting his technique without using any anesthesia. And ether had recently become a used anesthesia during that time, but he chose not to do so. He had a number of experiments using slaves and Black folks that did not include gynecological care. One of the most extreme was his use of Black babies for an experimental surgical procedure to cure neonatal tetanus, as they called it at the time. This was caused by nutritional deficiency, but Sims was convinced that the cause was the displacement of skull bones at birth, And he was convinced of that for racist reasons. And these were based on assumptions in the medical literature at the time that had it that the skull bones of Black infants would fuse together more quickly than whites, leaving no more room for Black brains to grow. One of the reasons for, or one of the so-called reasons for the so-called low intelligence of Black adults. And so to combat this, Sims made incisions in the scalps of Black babies and then used a cobbler's tool to try to pry the bones into new positions. And he described in his journal that during this time, I would occasionally puncture the scalp over the lambdoidal suture with the point of a crooked awl and prise out the edges of the parietal bones, always with the effect of greatly modifying the rigid fluor of the extremities. To go back to his gynecological surgeries, of which he was most famous for, we know the names of 3 of the women who participated, Lucy, Anarcha, and Betsy, but the other women went unnamed in his diary. Lucy was an enslaved 18-year-old and the first that he used for experimenting with this repair. She almost died after Sims operated on her and left a sponge in her vagina to absorb the urine, which led to a severe infection. I switch gears now to talk about sort of early conceptions of human biology and how they were inextricably intertwined with the racism of the day. Just to sort of give you a tip of the iceberg, this is a report out of the Medical and Surgical Journal of New Orleans in 1851 by Samuel Cartwright. And Samuel Cartwright was one of the foremost in terms of doctors of his day who repeatedly published different treatises on race and with racist understandings of differences in human biology. And to quote in this report, I briefly enumerate some of the more striking anatomical and physiological differences separating the Negro from the white man. Attention is also called to the fact that the same medical treatment which would benefit or cure a white man would often injure or kill a Negro because of the differences in organic or physical characters imprinted by the hand of nature on the 2 races. The facts enumerated are just as well known and established in that branch of medicine embracing comparative anatomy and physiology as the size and motion of the planets in astronomy. And much of the science of this day, much of the biological science, human biological science of this day, really tried to emphasize the differences, the biological differences between Blacks and whites and everyone else considered in between. We saw a lot of emphasis on skulls and head shape because the skull was the seat of the brain and therefore the seat of intelligence, and Europeans imagined themselves as having larger skulls, or at least larger skulls in the forefront of the head, and therefore larger forebrains, which they had imagined then also was the seat of intelligence as compared, right, to the lower brains, which they thought of as the reptilian brain, and therefore sort of more that Blacks who had a larger reptilian brain were much better at simply following instinct and not higher levels of intelligence. One of the most pernicious racist stereotypes that emerged in the medical literature during this period was the idea that Blacks are less sensitive to, or less sensitive to pain. It is one of the most persistent and harmful theories of racial difference that leads today that in every single medical field, patients of color routinely have their pain undertreated, and that undertreatment exists along a spectrum. So the darker your skin is, the more or the less likely you are to have your pain adequately treated. And in this 1787 manual, British doctor Benjamin Moseley claimed that Black people could bear surgical operations much more than white people, noting that what would be the cause of insufferable pain to a white man, a Negro would almost disregard, right? And he illustrated that with extra colorful stories about amputating the legs of some Black folks who were actually able to sit and bear the pain and actually hold the limb themselves. And as I said, this was consistent in every field of medicine, even very particularly in pediatrics, right? Where efforts to demonstrate the racial differences between Blacks and whites, or to demonstrate that they were natural and hereditary rather than products of discrimination. And there were rampant and sometimes contrasting stereotypes of Black children that historically placed them into one of three modes. They were either described as hardy and super vital exotics, or aliens, or little monsters. I want to turn now to how we saw this manifest itself in medical schools specifically, right? Black bodies in particular, both alive and dead, were used for experimentation and education throughout the 1800s and early 1900s. In the 1800s, medical schools competed for students by advertising their access to what they called as clinical material, but these were Black bodies to experiment upon and to dissect in their gross anatomy labs. Black bodies were systemically found on dissecting tables and operating amphitheaters, classroom demonstrations, and laboratories. And white medical students had the expectation that their education would include and be based on the observation, dissection, and experimental treatment of Black bodies. There was a particularly huge demand for Black cadavers, who were often executed prisoners that were granted by the state to medical schools, and there was an extensive practice of grave robbing. If you visit any medical school archives that existed before, any medical school that existed before the 1920s, you will likely see something like this. These were images that became rites of passage in medical schools, and they were rites of passage depicting, right, first year gross anatomy. And the interesting thing about these photographs is that there were a number of tropes. One trope was to always usually pose with a skeleton somewhere in the background. The other was to pose with the body that they were dissecting in some grotesque state of dissection. And because of that, we can often see the skin tone and skin color of the bodies that were used. And the majority of them were Black. Seated on the bucket at the foot of the table there was the porter, who was there to clean up the mess after they were done. And they were often sometimes put in the pictures as well. Another trope that we see are these pithy little epithets that they would write on a chalkboard or something like that. This is from the University of Mississippi, 1915. Rest in pieces, a martyr to science. He lived for others and died for us. These were also put on postcards and mailed home. Such the vulture's love was the pithy epithet there. And on the back, best wishes for a happy Easter, etc. To turn now to the express practice of using and exploiting Black people for human subject experimentation. This quote by Harry Bailey, who was a neurosurgeon, and during a 1962 address to Tulane Medical School, pretty much sums up the history before we get reform in human subjects research at the federal level in the aftermath of the civil rights movement. I give you a few examples to sort of illustrate this. These were some of the most egregious or some of the most widespread. Starting off with a series of testicular transplant experiments that were done in a San Quentin prison in the early 1920s by Dr. Leo Stanley, who was the chief surgeon there at the time. He was inspired by early 20th century eugenics theories that hypothesized that many illnesses were ultimately related to the vitality of the gonads. So he removed testicles from goats, lambs, and executed prisoners and surgically implanted them into over 500 prisoners there at San Quentin over a number of years. And he was imagining that this procedure would be a cure for crime and senility. The extracted testicles were either inserted into the prisoner's scrotum or into the abdominal wall. And he was undeterred by his early negative results that killed some of the subjects. And the study was actually allowed to continue for over 8 years. This was not only relegated to the United States, and this was not only relegated to Black people as well. There was a large Puerto Rican prison cancer study that was conducted by Dr. Cornelius Rhodes, who was a pathologist from the Rockefeller Institute for Medical Research in New York. And he was invited down to Puerto Rico as part of Rockefeller's Sanitary Commission to conduct clinical research at a hospital there in San Juan, Puerto Rico. Of course, Puerto Rico became a US colony acquired at the end of the Spanish-American War in 1898. And Rhodes established a 200-bed ward at Presbyterian Hospital, using all the patients there as research subjects without telling them. And in the beginning, he mainly studied tropical diseases, referring to Puerto Ricans as experimental animals. But later, he used prisoners in Puerto Rico to test whether cancer could be spread by direct injection of malignant cells into a non-cancerous patient. And he purposefully hid the details of these experiments from the subjects. And we know that at least 13 of those subjects died from his study. In a letter to another doctor that was leaked to the Puerto Rican Nationalist Party, he wrote, and this is an eye toward what his motivations were, that, quote, "The Puerto Ricans are beyond doubt the dirtiest, laziest, most degenerate and thievish race of men ever inhabiting this sphere. It makes you sick to inhabit the same island with them. What the island needs is not public health work, but a tidal wave or something to totally exterminate the population. It might then be livable. I have done my best to further the process of extermination by killing off 8 and transplanting cancer into several more. The latter has not resulted in any fatality so far. The matter of consideration for the patient's welfare plays no role here. In fact, all physicians take delight in abuse and torture on the unfortunate subjects." And I don't have the time to get into it, but after this study down in Puerto Rico, Rhodes was promoted back at home. He became one of the leaders in the atomic agency here for working for the US government. He oversaw numerous radiation testing experiments that took place in many poor public hospitals across the nation on poor patients of color that were subjected to total body radiation of a nuclear war scale, but telling them that they were actually being treated for their cancer. In the post-slavery period, a lot of the exploitative research took place in prisons, and one of the largest prison experimental facilities was Holmesburg Prison in Philadelphia. And it became the training ground, the premier training ground for medical students and residents in dermatology. By the late 1960s, it was the largest and best known in the country. And they did expansive phase 1 testing of both pharmaceutical and commercial products. And these included subjecting prisoners to radioactive isotopes, dioxin, hallucinogenic and capacitants, and various other chemical warfare, viral, and cancer studies. And because of that, Holmesburg is now closed, but University of Pennsylvania still has one of the premier dermatology programs in the US. I also want to mention briefly what was probably part of the height of racialized science that occurred along with the eugenics movement. And we can summarize the eugenics movement with this very first paragraph here in this article from the Los Angeles Times Sunday Magazine. And this is an article from 1908. It says, "Our modern industrial and social life is reduced to the struggle of the biological effectives, the fit to provide for the maintenance of the hereditary defectives or the unfit." And this was the overall logic of the eugenics movement. It was the idea that all our social status was caused by our inherent biology and what we inherited from our parents, right? And therefore, the eugenics movement was a dream at bioengineering society by eliminating the biologically unfit and supporting the increased reproduction of the so-called biologically fit. And it represented the apex of racialization of biomedicine. It constituted an application of Darwin's theories of natural selection to human and social arrangements. It was rooted in the idea that race, socioeconomic status, and social hierarchies were all biologically determined and inherited. It saw over 50,000 people involuntarily sterilized in the US. Most of the involuntary sterilization laws were repealed after World War II, but the practice remained for many decades after that in the South, where it was colloquial named the Mississippi appendectomy, as a lot of Black women in particular would go in for medical procedures and come out later, find out that they had been sterilized against their knowledge and against their will. Eugenics is the precursor to contemporary genetics. And it also provided the intellectual foundation for the Nazi genocide programs. The US started its involuntary sterilization eugenics programs in 1907. Germany did not start theirs until 1933. And they drew heavily on US scholars to help them establish their eugenics program. And most importantly, what I want you all to realize is that it often gets described as a pseudoscience. And at the time, it was not considered a pseudoscience. It was regarded as a progressive, scientific, and humane way to deal with the so-called race problem. So this history has seen race systemically built into algorithmic decision-making throughout the field of medicine that we still live with today. For a deeper dive into this final topic that I'm going to cover, I highly suggest taking a look at this article in the New England Journal of Medicine, Hidden in Plain Sight, Reconsidering the Use of Race Correction in Clinical Algorithms, and what it looks like in over 22 different medical fields. We have algorithms that help doctors predict and decide upon when to provide care and when to intervene based on a patient's health complaint. For instance, for asthmatics, it has been, measurements in spirometry that we often use to determine lung capacity. However, many of these algorithms have race corrections built in. In the US, spirometers apply a correction factors of between 10 and 15% for individuals labeled Black, and 4 to 6% for those labeled Asian. And we can trace this correction back to Thomas Jefferson's note on the state of Virginia, where he discussed the deficiencies in the pulmonary apparatus of Black folks, and it is maintained in our culture to this day. Plantation physicians used Jefferson's statement to support slavery, believing that forced labor was a way to vitalize the blood of slaves. Samuel Cartwright, again, who I mentioned earlier, was the first to use Hutchinson's spirometer. Hutchinson was the original inventor of the spirometer to record deficiencies in the pulmonary function of Blacks. And also there was a massive study of Civil War soldiers that validated these results. And subsequently, Gould published the Civil War study in 1869, reporting that full Blacks have less lung capacity than whites, without taking into context why that might be, what their working and living conditions were, what toxins they were exposed to. And he analyzed his data without any adjustment for height, age, attention to working and living conditions, or newly emancipated slaves, right? And we can see, we zoom in right where the race correction is on this apparatus. Of course, now all of this takes place digitally on a computer, and we see it in a number of different fields. Just to give you a few more examples, in cardiology, there's the American Heart Association's Get With the Guidelines Heart Failure Risk Score. The input variables you see there at the top, but they also include race, and the race correction adds 3 points to the risk score if the patient is not Black, which increases the estimated probability of death. What this does when the race correction is added into the calculation, the result is a clinical inequity, right? Where it regards Black patients as having lower risk, thus raising the threshold for using clinical resources on Black patients. Similar, last example would be the kidney donor risk index, right? It also, in terms of input variables, has race as one of the input variables. And what it does, it increases the predicted risk of kidney graft failure if the donor is Black, right? And when put into the calculation, right, a clinical inequity results, it not only reduces the pool of Black kidney donors in the US, but also reduces the pool of eligible kidneys for Black patients. Like I said, there are over 24 of these in different fields of medicine. And despite that, the fact that racial health inequities exist across the board in every single clinical field of medicine, none of these race corrections are designed to help enhance the screening, assessment, or care of patients of color. Each and every single one of them works to the benefit and enhance protection of white patients, yet they are guised as tools to help increase efficiency and prevent the waste of medical resources. And so we ask ourselves, why are they so popular, right? And I offer to you in conclusion, that these race corrections offer a kind of cognitive get out of jail free card for the medical profession, whose practitioners don't have to bother asking the question of why, the answer to which usually always points back to the impacts of structural racism and how it shapes health outcomes in all of the following, whether we're talking about stress and accelerated aging, income, education level, health insurance status, wealth accumulation, neighborhood and environmental toxic exposures, food delivery systems, or zoning laws, right? Urban and rural infrastructures, all of the above, and access, to healthcare. So in conclusion, right, the history of this mistreatment that I've tried to outline also briefly, and this is really just the tip of the iceberg, right? It leads to our present and futures of distrust. These stories of racist mistreatment get handed down in communities over generations. Our continued racial profiling in clinical settings, unequal treatment that patients of color are subjected to, their disregard when they make complaints about their health status, and they are treated as not knowing what's going on with their bodies, and the blatant disrespect in clinical settings all exacerbate this legacy. And overall, we need an honest accounting and acknowledgement of this history in order to facilitate community conversations about how to repair this trust. And then once we have those conversations, we actually need institutions as well as our government officials to implement these measures aimed at repairing trust. Individual providers should acknowledge this history and encounters with patients of color, particularly when they detect that there seems like barriers to developing rapport, and identify themselves as an ally in overcoming these harms, if that's what's genuinely in their heart and desire to do. And then we must further ally ourselves against policies like the war on drugs, unequal school funding, voter suppression, the assault on women's reproductive health, that are structural determinants of continuing health inequities. Those are just, the tip of what we need to be doing to really address this legacy. But the meat of it is really, having an honest accounting as a nation, as a community, looking at how this is manifested on the local level and not just how it has manifested on a national level. So I thank you. Here's a number of additional resources for those who want to take a deeper dive. And like I said, this was really a quick and dirty, but tried to really give you an overview of all the different domains where this has been an issue. So I will stop my share.
Dr. Glenn, thank you so much. Thank you for that. I'm sorry, Christina, Dr. Jimena and I have been messaging, and I'm just going to go a little bit off script from our original plan. So it's 3 minutes of the hour, but I want to make everyone aware that Dr. Jimena and I are going to stick on the video past the hour. We understand that this was a really intense, emotional, and incredibly important conversation that we're having, and we are glad to stay, have discussion, and make time for that. First, in addition to the gratitude for Dr. Glenn, I just want to encourage all of us to take a really deep breath. Like, we have a tendency when we're hearing this content, our breath can become a little bit shorter. I personally can feel a bit nauseous. We may be reflecting on our own experience, our own lived identity, how this relates to the work that we're doing around vaccine, how it relates to our lived experience in the pandemic. So I won't put Stacy on the spot, but I don't want her to judge my breathe work here either. So we're just going to do it really slow. Let's try to get at least 3 to 5 counts in and out. I just encourage you in the next couple of hours, keep remembering that. If you see your breath coming shorter, take another deep breath. If you have the space in your schedule and you need to step away, make a phone call, sort of talk through any of your experiences that are coming up. Reach out to me too. I will also make myself available. So Dr. Jimena, did you want to do your sort of closing announcements, and then we'll transition to questions and discussion?
Sure, that sounds good. And thank you, Dr. Glenn, that I learned so much. Thank you for being here. I wonder, Christina, can you put the slide deck up? I just wanted to give a little preview of where we are going from here. So sort of like where we've been. So the last 5 months we have spent talking about barriers to vaccine. Today was the beginning of our second unit or chapter, which is public health in the context of a pandemic. And we're going to continue with this topic through probably October, and then at the end of the year, do a wrap up. So just a little preview for what is coming. If you could take down the slides. Is there anybody that wants to make any announcements about things that are coming up? Okay. Well, we'll wrap up the formal meeting, and like Courtney said, I'll stay on, and Courtney too, if anybody wants to stay and talk about what we just listened to. I don't know, Dr. Glenn, if you have a little time, but don't feel obligated, but if you did, we'd love to have you. Thank you, everybody. See you next month.
Thank you. I think at this point, if it's possible to stop recording, that may help with some of the candor and discussion.